That's right. Yeah. No, I trust the evidence, read the evidence, know that what you're doing is going to benefit that patient in the long term. So yeah. And so I think every paramedic should sort of be happy that the doors are opening up, right? And we're able to provide more of these treatments pre-hospital, because there are a lot of things that patients should get as soon as possible, from time to injury to administration is important. TXA is one of them. So I'm glad to see that's coming down for you guys.
I think one of the hesitations that we've seen from the medics as we talk about it, because it's new and you're starting to think about it, is I think people are 100% on board with it's kind of like the scene call, right? They're 100% on board with that person who the life threat is obvious. You know, they're definitely bleeding. They're super sick. But that's not necessarily the only function of TXA. It would be for anyone with that suspected bleeding. We got a few people scoffing at the, suspected hemorrhage with a heart rate over 110, but really we're just looking at mechanism, the potential for bleeding, and then signs of, I guess, compensated shock to say, hey, we got to get this in early. Is that kind of along the lines of your perspectives on it? Like, regardless, you don't have to be the sickest of the sick to get TXA, I guess is what I'm asking.
That's right. I'm not waiting until you're unstable before I give TXA. So if we have a multi-system trauma and you're tachycardic and you have a tender belly, you're getting TXA. You might be compensating. So, you might look pale, diaphoretic or clammy. Your heart rate's maybe 110, 120, because that's not normal. And so, yes, you might be in pain, but I'm going to assume that the fact you were just hit by a car and that you have a tender belly, your pelvis is tender, maybe I've even wrapped your pelvis because I'm concerned that it might be fractured. Maybe I've had a hard time getting an IV in you because you're all shut down. Well, guess why you're shut down? Because you're compensating. And maybe your blood pressure is 100 or 110 systolic. But I'm thinking to myself, well, normally you should be 130, 140 because I can see you're on an antihypertensive medication. Or maybe with your heart rate at 120 and the fact you're screaming in pain, I would expect your systolic to be higher, but it's not. It's only 100. So when you look at the overall presentation of the patient, the mechanism, their injury pattern, and these subtle signs of increased tachycardia, pale, clammy condition, weak peripheral pulses, all that's painting a picture of a patient in hemorrhagic shock who's compensating. And so I'm not going to wait for you to drop your pressure to administer TXA. You're getting it now, and I'm preparing to start resuscitating you because I know it's coming. I know it's about to happen. So that's all part of the plan.